Virtual Implant Expo. So we just had inaugural ceremony of second Virtual Implant Expo that is being organized by Dentistchannel Online. So the second World Implant Expo was inaugurated by President of Karnataka State Dental Council, Dr. Rangnath Visar. So with this outset, we are now set to the first scientific session of this edition of World Implant Expo. So we have our distinguished speaker with us. So before going into the session, I would like to introduce about the topic and also about the speaker. So we all know that clinical anatomy, that is anatomy, is the foundation for any of the surgical procedures in our field. So for the topic of this session is Basics Revisited, Clinical Anatomy for Successful Implant Placement. So in-depth knowledge of anatomy is of utmost importance before actual planning and placement of dental implants, because anatomical knowledge is vital not only for the safe and successful execution of the surgical procedure, but it's also important for accurate diagnosis and treatment planning as well. And we need to respect certain clinical landmarks and boundaries so that we have better clinical outcomes. And complications also can be avoided by proper assessment of the anatomical structures beforehand. So with this, I would like to introduce our distinguished speaker for this session. So we have Dr. Vishruti with us. So she has completed her Bachelor of Dental Surgery degree from Sharad Pawar Dental College, Savangi in 2013. And then she has a certification of Global Tobacco Control Trainer from Johns Hopkins Bloomberg School of Public Health. And also to add, she has a professional certification course done from Indian Dietetic Association. She has also a fellowship in cosmetic dentistry from Apollo White Medavarsity University. She has undergone intensive clinical training in soft tissue lasers in the year 2018. And to add to her feathers, she has fellowship in oral implantology from Common Dental College, Mumbai, which she has completed recently. And she has been very active in all the continuing dental education programs, scientific conferences, and she has also won several awards for her presentations, for her posters and scientific presentations. So with this introduction, I hand over the stage to you, ma'am. Please continue with your scientific session. Thank you. I request all the participants to stay with us during all the scientific sessions of this scientific extravaganza of second World Implant Expo. Once again, I extend hearty welcome to you, ma'am, and also to all the participants for this World Implant Expo. Thank you. Please continue.
Thank you, Ashwin, for the great introduction. And I would like to thank Dentistchannel for organizing this and also giving me the opportunity to share my knowledge. And I would also like to thank the participants, because taking out time in the time of Diwali is little crucial. So thank you for that, and happy Diwali to all. Let's start the presentation with a positive note. So good morning to all. So before we go to the presentation, I will first like to introduce myself, say something about myself, that I have been practicing in Mumbai since last 8 years. And now I'm associated with the Aesthetic Clinics, Mumbai, India, which is a world-class centers all over the India. So with great power comes great responsibility. So as an implantologist, we all are implantologists. So as an implantologist, it's our responsibility that we should respect the anatomy. And before going to anything else, we should know about it. So the topic is Basic Revisited. So let's revisit the clinical anatomy for successful dental implant treatment. So it said that first we should unlearn what we have learned to relearn the basics. So after the webinar, you will be able to understand the surgical importance of the anatomy in relation to the practice of implant dentistry. Also, after knowing the anatomy, you can easily avoid the surgical complications with proper planning and giving importance to the preoperative and postoperative anatomical landmarks, which many clinicians are unaware of, surprisingly, and its clinical significance during the surgical and prosthetic phase of implant. So anatomy is the first step of dental implant planning and precise surgery. So the careful perception of anatomy provides professional with the confidence to deal with hard and soft tissue, which will restore the exact what is our aim of implantation, which is functions and aesthetics. So once we achieve this, the end result will be a good healthy life and a quality of life which we can give to the patient. So I'll be discussing very briefly about maxilla, mandible, and these are the key structures which we will be going into the detail. That is maxillary sinus, nasopalatine foramen, and mandible, inferior alveolar canal, mental foramen, lingual foramen, retromolar foramen, and the genial tubercle. So as we all know the basics about the maxilla, that is maxilla, it is a pyramidal in shape. So, okay, so it's pyramidal in shape. So there are two maxillae bone which joins at the center, and it forms the part of orbital floor, nasal cavity, hard palate, and the alveolar process. The relevant openings are the infraorbital foramen, posterior superior alveolar foramen, incisive foramen, greater and lesser palatine foramen. We all know about this. So maxilla is a force distribution unit. Okay, so it distributes the force and it redirects away from the brain and orbit. So now the mandible, when we say the mandible, it absorbs the force. Now this is very important. Now, when the maxilla is distributing the force and mandible is absorbing the force, so the mandible have the bone is more cortical, okay, because, and it's very dense in the mandible. Opposed to the maxilla, it's more of a cancellous kind of bone. So Mish has divided, we all know about the bone density classification by the Mish, that he have given the classification from D1 to D5. So D4, D3, D4, D5 being a more of a cancellous bone and it has a thin cortical plate. So maxilla, it comes under D3, D4 kind of bone. I'll show you the picture. So as you can see in this is a very dense bone, D1. This is a D2 kind of bone. These are found in the mandible, and this is a very thin, you can see here, there is a very thin cortical bone and a cancellous bone in between. So D3 and D4 are found in the maxillae. Now, why it is of a clinical importance? So let's go through this. See, as we can see, D1, D2 are mostly found in the mandible. D3 are found in the D3 in the anterior maxilla, and D4 in the 50-50 on the anterior and posterior maxilla. So, so how we determine it? This. So with the help of, you can see it in the CBCT scan or the CT scan, you can see what the bone density is, whether it is D1, D2, D3, D4. So it is calculated in the form of Hounsfield unit. Hounsfield unit, as a reference, we say that -1000 is a air, 0 is 0, and a +1000, which is a bone. So it is a denser. So Mish has classified it according to the Hounsfield unit as 1250. Greater than that will be D1 kind of bone, excellent bone. D2 will be 850 to 1250. D3, D4 will be seen in the maxilla, which is 350 to 850 and 0 to 350. So the bone density is very critical and very important coming to the implant planning. So when we see the strength of bone, it is directly related to the density of bone. So when I say the bone is more dense, it will have more strength. So D1, D2 have a greater amount of strength, and D3, D4 will have comparatively the lesser strength than the D1, D2. Similarly, we can say that the failure prediction we can assess. So now when I divide it in the grade of 1 to 10, suppose the bone dense, the strength, so being 10 will be the higher. So 9 and 10 will be seen in the D1, D2. Then coming 7 and 8 will be seen in the D2 kind of bone. D3 will be 50% of the D1, D2, and D4 will be the very less. So it will be around 1 or 2. So when the strength is more, failure prediction becomes less. This is a very beautiful diagram from the mesh where they have given D1, D1, D2, D3, D4 in a division A kind of bone. So in D1, D1, D2, there will be no failure prediction. In D3, the strength is less, but still it's a good bone. And it's said that D3 and D2 are the most ideal bone which we see for the implant placement, because it has good amount of cortical bone also and a cancellous bone also, which provides the blood for the osseointegration. D4 failures are most commonly predicted. Now we have to, while planning, if we have a D4 kind of bone, we have to certainly modify our treatment plan according to it. We'll see it further. Then the modulus of elasticity. So the modulus of elasticity is the stiffness of material. So the implant is less flexible than the elastic modulus of the bone. So there are micro movements which happens between the implant and the bone. So this will lead to the implant failure. More mobility is seen in the kind of D4 kind of bone. So D1, D2 will have less mobility. D4 has a more micro movements happening between the implant and the bone. Because of the, you can see in this diagram, the titanium, the modulus of elasticity and D4, the difference is much more higher. More the difference, more will be the micro movements happening. So now what you can do in this? So as we know, the stress is equal to force upon the area. So what we have in our hand is an area which we can see. So whenever there is less bone density, suppose it is a D4 kind of bone, we can increase the implant surface area so that we have less amount of stress on the less amount of stress and less implant failure. So how, and decrease the force. One is increasing the surface area. Either if you are knowing that the bone is around D3 and D4, there you cannot put a short implants, because we know we have to increase the surface area. So you will use an ideal implant size over there. Or if the bone height or anything is less, you can go for an augmentation procedure and then select the implants, rather than going for the shorter implants. But if it is an anterior mandible where the bone density is good, you can go for shorter implants as well. So to decrease the stress, we have to increase the area and decrease the force. So how you are going to decrease the force? Decrease the force by ideal implant position. You have to check for the parafunction, any forces, and the favorable occluding opposing occlusion. So coming to the next important anatomical is a maxillary sinus. Now, maxillary sinus, we all know it is an air-filled space which is covered by a respiratory mucosa. So this is a theoretically, we know that it reduces the weight of skull, phonetic resonance, warming, humidification of inspired air, and olfaction. These are all the role of sinus, which is theoretical. Now coming to the boundaries. Now it's a, we can see over here, it's a pyramidal in shape. Okay. Now it has 5 surfaces. Okay. So the anterior wall, is a facial surface of a maxilla, this facial surface of the maxilla, and it is internally glued by the canalis sinuses. This canalis sinuses is very important and most of the clinicians don't know about it. So the canalis sinuses is mostly misdiagnosed as an apical pathology of cuspid. What is canalis sinuses? Now we know there is a nerve called as infraorbital nerve which traverses through the infraorbital foramen. Now this nerve, it extends further anteriorly, as we can see in the image, it extends further anteriorly as a canalis sinuses through which posterior superior alveolar nerve passes. Now this is mostly seen in the palatal to the cuspid area. Okay, so mostly it is misdiagnosed as something apical pathology, some apical pathology is there with the cuspid. So why it is of clinical significance? if we go into this, if there is any intervention in this area, there can be a soft tissue interface. Now, if there is a soft tissue interface, you might end up going to a fibrous healing, which we don't want. Then there can be a failure of implant, temporary and permanent sensory dysfunction, and the bleeding issues. So these are the boundaries. So base of the maxillary sinus is the lateral nasal wall. We can see this in image. So base is at the lateral nasal wall and the apex is towards the zygomatic bone. Apex towards the zygoma and base towards the nasal cavity. Roof is formed by the orbit and posteriorly the infratemporal fossa and pterygopalatine fossa. Now, the maxillary sinus, it expands. Okay, so expansion of maxillary sinus is laterally, that is towards the zygoma, it's laterally and inferiorly. Okay, so it may invade the canine eminence region. If it is going, if it expands, it might invade in the canine eminence region or in the piriform of the nose region. So this normal maxillary sinus, it may expand like up to this area. So mostly we found that in the posterior maxilla, we have very less amount of bone. Why? Because there is a dual resorption which is happening. Usually in the edentulous area with the posterior teeth loss, there is expansion of maxillary sinus happening. And also there is resorption of the crest of ridge. So that's why there is very less amount of bone which we found in the posterior maxilla. Also, because of this, many vital structure, they come close to the ridge. So we have to be this point is very critical where we should do a proper planning. This maxillary sinus have various variants, which we should know, because most of the maxillary sinus, when we go for a sinus lift and all, we come across this anatomical variants, which causes complications further. So now when I see, this is a most common variant. Okay, this is a maxillary septa. So now this is a maxillary sinus. When we see from the top, this is a maxillary septum. So this is a most common anatomical variant. Now, why this is of these are of two types. One which is present congenitally, that is primary, and one is which is secondary due to pneumatization of antrum after tooth loss. As I said, it expands. There is filling of air in the sinuses. Because of that also, there you can see a maxillary septum. As we can see radiographically, it is like quite well seen. So, but we should know. So it's important to know it. If you don't know, you will not be able to see it. So this is a maxillary septum. So once you come across this, your planning and everything changes prior to going for the surgery. So what are the see, the incidence of perforation of sinus membrane is reported at 42.9% when the septa exists. So, and 23.8% when it is absent. So it is going down to 50%. So 42% is very high. So whenever there is septa present, most of the time you might perforate the sinus membrane. So if you perforate it, there will be a problem in visualization because of inadequate access. Inadequate sinus grafting will happen and the membrane perforation. Coming to the blood supply of the maxillary sinus. Now the maxillary sinus is mainly supplied by the maxillary artery. A sound knowledge of arterial supply of maxillary sinus is mandatory for surgical procedures involving in the area such as sinus floor elevation, implantation of the grafting materials. So what is it? So this maxillary artery, mainly the infraorbital artery and the posterior superior artery, they supply the maxillary sinus. Now there is something called as an extraosseous anastomosis and intraosseous anastomosis. So there is anastomosis between this infraorbital and posterior superior artery. The arteries which are going through the bone are called as an intraosseous. And then it comes. So now here we can see in the diagram that the artery is coming outside and then it invades the bone, and then from it inside you can see this. So this is extraosseous and intraosseous anastomosis, which encircles the maxillary sinus. Now there is a crucial height which you have to remember, that is 15 to 20 mm from the dentate alveolar crest. So extraosseous anastomosis is superior to the intraosseous anastomosis. So this is an extraosseous anastomosis. Here we can see it is superior to the intraosseous anastomosis. So it is 15 to 20 millimeter from the dentate space, and the intraosseous will be 5 to 10 millimeter from the edentulous ridge. See, when the artery goes through the bone, it is intraosseous. Here also we can see. So why it is of clinical importance? Now, damage to the anastomosis during the reflection of flap. So most of the time, whenever there is resorption of a ridge, so these arteries are more closer to the crest. So there you can, damage this, and whenever you're reflecting the flap, there can be damage to this artery, which will lead to the increased bleeding. So problem with the visualization and effectiveness of your surgery. So increased surgery duration as well. Post-operative complications will be pain, edema, and ecchymosis. One second. Okay. So there are some anatomical variants which are seen in the maxillary sinus as well. So now I want you to focus on this area. This is called as an osteomeatal complex. Okay, so most of the time there is a nasal septum deviation which is seen in the 70% of cases. So in this, what happens? This area gets compressed. Okay, so this nasal septum, if it is deviated to this side, this complex gets compressed, because of which there are more chances of sinusitis in the maxillary sinus. So here you need to remember that if you come across such patients, because this is 70% of time, you might come across with a patient who have a deviated nasal septum. So in this case, whenever you are doing a grafting, at the same time, the implant placement should not be done, because of the chances of sinusitis is more. There can be an infection and then the failure. The second is a supplemental ostia. This is not that relevant. The next is the inferior turbinate or meatus pneumatization. That is a big nose variant. Now, as you can see in the image, there is a pneumatization which has happened, and the maxillary sinus is very much lateral to the edentulous ridge. So if our implant, we have to place it over here. Okay, so most of the time, if we are unaware of this, we might end up going into the nasal cavity. Also, the sinus graft in this case is contraindicated. We should go for an onlay graft. The next important anatomical aspect is a nasopalatine canal and incisive foramen. We know all basic about this already, that it connects the oral cavity with the floor of nasal cavity. So these are some dimensions. That is, it is 7.4 millimeter away from the labial surface of unresorbed maxillary anterior ridge. The mean diameter is 4.6. Length 9 millimeter, height 10.08 to 10.86, and angle is around 46 to 99 degree, which varies. Now, these are beautiful pictures. Again, you can see here, there's this nasopalatine canal. This is foramen. Now, this foramen most of the time is a problem while implant placement. If it is big, then the implant placement becomes very crucial. So approximately 4% of nasopalatine canal directly affect the ideal positioning of implant in the premaxilla. The incisive foramen often expands laterally within the palatal bone. Now this incisive foramen, it expands laterally within the palatal bone. See here, this is, if you can see this picture, that you can see this is a buccal plate, this is a palatal plate. So it's expanding to the palatal aspect more. It expands laterally within the palatal bone. Formation of the fibrous tissue at the interface in the mesiopalatal region. So it is important to differentiate here the enlarged canal from the incisive canal cyst. From the enlarged canal with the incisive palatal cyst. Incisive canal cysts are known to cause local dilation of these canals with possible displacement of the teeth. Okay. Now in this picture, we can see the implant which is placed in the canal, which is impinging the nasopalatine canal. Okay. This might lead to the bleeding and the implant failure. There will be lack of osseointegration as well, because it is in contact with the neural tissue. And we want it to be in contact with the bone. Next important is an infraorbital foramen. Now, infraorbital foramen, we all know how to palpate it, right? Externally, internally, as we give the infraorbital block, first we palpate the infraorbital foramen. So it is located in the anterior aspect of maxillary bone below the infraorbital margin. The distance is approximately 6.1 to 10.9 millimeter. Now, whenever there is resorption of ridge, now this we can see in this picture, this is an ideal bone alveolar process and foramen length. But whenever there is resorption of ridge, this distance decreases, because of which the whatever the nerves are traversing, the arteries are traversing through this area, will be in close proximation with the ridge, which might lead to the complications further. So this is a normal location of infraorbital foramen, and this is a variation closer to the ridge. So the muscle attachment of the maxilla. So I'll be not discussing all the muscles. I'll be only discussing which are more important. So one is an orbicularis oris muscle. So we know the orbicularis oris muscle, which originates from the modulus at each corner of mouth. So what is modulus? So this is a modulus where 8 muscles meet at the corner of mouth. Okay, this is very important when with the implant aspect also. Also, it is important when we go for nowadays we go for aesthetic treatments like Botox, fillers, and various other treatments. So here, the orbicularis oris muscle originates from the modulus at each corner of mouth. So the orbicularis oris fibers, they attach to the alveoli of nose and to the nasal septum. Alveoli of nose and to the nasal septum. Buccal and mandibular branch of facial nerve, they supply them. Now, why it is of importance? See, this orbicularis oris and the buccinator muscle, they are deeply attached into the submucosa. Yeah. So submucosa of buccinator and orbicularis oris muscles are strongly attached to the cheek and lip area. Now, when surgical procedures such as guided bone regeneration is done around this area, see, it is very important whenever you're giving the incision and closing the flaps, there should be a primary closure. Right? It should be a tension-free flap. So if it is the flap, if you are closing the flap which is very much tensed, okay, then there might be necrosis inside, incision line opening, causing all the bacteria and everything will go inside and will cause necrosis. So we don't want that. So here there is a role of this orbicularis and buccinator model. We have to go inside whenever we are doing the incision. We have to fenestrate and penetrate into the several millimeters into the mucosa. Okay, so that we are releasing these muscles and there is a tension-free flap. The next muscle is an incisive labii superioris muscle. The incisive labii superioris muscles originate from the floor of incisive fossa of maximal and above the eminence of the lateral incisor, and it goes deep into the orbicularis. This, 1 second. See, this is the muscle. Okay, now it is attached deep into the maxilla and it goes into the inserts into the orbicularis oris muscle. Now here we need to know that this muscle has two fibers. One is septalis fiber and one is a oblique fibers. The septalis fiber, it goes into the skin of nasal septum and oblique fibers to the ala of nose. Whenever there is damage to the septalis fiber, it will cause drooping of the nasal septum. So whenever after doing a procedure in the anterior maxilla, a patient comes with a drooping of the nasal septum or a flaring of nose, these muscles are involved. So drooping of septum is because of septalis fiber, and because this oblique fibers are attached to the ala of nose, there will be a flaring of ala of nose because there is no reattachment of this muscles after the procedure. Here we can see the bony attachment of the muscle into the maxilla. Next important is the buccinator muscle. Okay, so buccinator muscle, it originates, this diagram is important. So it originates from the alveolar process of first, second, and third molar. Okay, alveolar process of first, second, and third molar. It goes into the pterygoid hamulus of the medial pterygoid plate and maxillary tuberosity. So it traverses like this, and then it again comes back and goes into the alveolar, and it inserts into the alveolar process of the mandible. So this buccinator muscle is of clinical importance because whenever we are going for a subperiosteal frame design, okay, the extension of the subperiosteal frame design into the pterygoid plates will interfere with the fibers of these muscles without adding too much to the retention of the implant. So here we should know the origin and insertion of muscles and where not to extend our subperiosteal frame. Next important muscle is a levator anguli oris, which is known as a caninus muscle. Now it originates below the infraorbital foramen. Infraorbital nerve and vessels arise between caninus muscle and the levator labii superioris. In severe atrophic maxilla, division D maxilla, infraorbital foramen. Now this infraorbital foramen is closer to the ridge. See, this is they have this lines, it says about the resorption pattern. So this is mild, this is moderate, and this is severe resorption. So in case of severe resorption, it is closer to the infraorbital foramen. So reflection of tissues for the autogenous graft and implant placement into sinus graft may approximate in this region and can cause paresthesia. We have already discussed this. Coming to the sensory innervation of the maxilla, it is mainly supplied by the maxillary nerve, which is a division of a trigeminal nerve. So here we can see that the nerve leaves the middle cranial fossa, okay, through the foramen rotundum. So this is foramen rotundum. It leaves the middle cranial fossa through this foramen, and it appears in the pterygopalatine foramen and again travels to the floor of orbit through this infraorbital foramen, and it comes out. It gives branches to the face. Now the posterior superior alveolar nerve. Now the maxillary sinus, it gives the innervation to the maxillary sinus, maxillary molars, buccal gingiva, and adjoining portion of the cheek. Care should be taken during sinus augmentation and it may damage the nerve. Then the infraorbital nerve. Okay, so the infraorbital foramen is located between two muscles. One is levator labii superioris muscle, which takes origin above the foramen, and the levator anguli oris muscle, that is caninus muscle, which takes origin below the foramen. So this is levator labii superioris, and below is the levator anguli oris. In between there is origin of this foramen is located in between them. So the foramen and neurovascular contents are within 5 to 10 millimeter of the extremely resorptive maxilla. Fixation screws or implants may cause paresthesia when inserted through graft and into these structures. Then comes the middle superior alveolar nerve. It supplies the maxillary premolars. This region is routinely violated in the lateral approach of sinus graft with apparently no consequences. Coming to the greater palatine nerve. Now, this is of a clinical importance. Now, it supplies the hard and soft palate. Okay, it enters through the greater and lesser palatine foramen. So it travels, there is one groove present over here, that is palatine groove. Okay, so it traverses through this groove. Okay, it extends anteriorly, and here it forms the anastomosis between the nasopalatine and the greater palatine foramen. So it communicates with the nasopalatine nerve further. This is nasopalatine nerve, this is greater palatine nerve. It meets at this point. Now, as we all know, so we should know the resorption pattern of maxilla. So maxilla, it resorbs from buccal to palatal. Whenever there is resorption of maxilla, it goes buccal to palatal. So that's why usually we see that the patients with long term of edentulism in the maxilla, they have very constricted maxillary ridge. Okay, so whenever this happens, there is resorption, okay, as the maxilla atrophies, it brings crest of the ridge closer to the palatine groove. Okay, it brings the crest of ridge closer to the palatine groove as compared to the normal. So whenever we are giving the incision, it should not be more palatal. Okay, if it is, the incision should not be too palatal to the crest of ridge in the atrophied maxilla, which might injure the vital structures. I hope till now you are with me. So this was all about the maxilla. Coming to the mandible. Now, mandible is a U-shaped bone formed by the fusion of two separate halves at the mental symphysis. Now, from the side, if you see, there is one ramus, there's a body, and which joins as an angle of mandible. Okay, now inside, if we see lingually, there is a lingula mandibular foramen through which there is goes a mandibular canal, conoid process, condylar process. This all things we already know. Okay, so coming to the anterior mandible. Anterior mandible, as we have already discussed about the density of bone, it is the D1 kind of density which is mostly found in this area. It is safest and most predictable region for the implant placement. But here we can see n number of variations in the ridge. So here we can see that this is a pear shaped, this is sickle shape, this is ovoid shape, triangular, buccal constriction, lingual constriction, and the hourglass. So most commonly you can see the pear shape, okay, but usually when we clinically do it, this is not the case. Okay, most of the time you will find that this lingual constriction or this kind of sickle shape you can see. So what to do? Okay, so we have to do augmentation. The augmentation is must in these cases, especially in the hourglass kind of. Otherwise, there is definitely a perforation of the ridge. See, implant is a prosthetic driven procedures. So we can place implant in this hourglass kind of ridge, but whether you will be able to achieve that proper occlusion, no. So first augment the bone and then place the implant. Otherwise, there can be a perforation. See, this is a lingual concavity which we can see. This is an improper placement of implant. So perforation of lingual cortical plate is most common, which will lead to arterial bleeding, that is facial, because of facial or lingual artery. Perforation of submental artery or sublingual artery will cause bony perforation and bleeding, okay, which might lead to the sublingual hematoma, which is a life-threatening situation. And if this occurs, if this happens, Okay, the patient, you should make the patient sit in the upright position, and and as the airway is compromised, the immediate emergency assistance should be done. Also, what you can do is you can bimanually give a pressure over there so that the bleeding is at least stopped. Coming to the medial vascular canal. Now, it is a radiolucent canal. It houses the bilateral sublingual arteries that enter the lingual foramen, which is located on the lingual aspect of the mandible. So there can be excessive bleeding, okay, if you place your implant in this canal, and there are no sensory fibers within the canal. To recognize this canal in the CBCT scan is very important and crucial, because most of the time it is not diagnosed only. Coming to the severely angled anterior mandible, this is one of these are all the variations which we can see in the mandible, anterior mandible. So one is a severely angled anterior mandible. As we can see in the image, it is severely angled. So usually in the division C, you can see the angle, the available bone height is very much like, it's good, it's adequate, but the angulation is more than 30 degrees. So available bone is adequate in height, but angulation is greater than 30 degrees regardless of the implant placement. Bone augmentation is must in this case. So what is clinical significance of this? If you don't go for the add-on procedures in this, you might poorly position your implants. There will be over contoured prosthesis, speech difficulty, compromised tongue space, inability to give a proper occlusion, which will ultimately lead to the implant failure. Coming to the posterior mandible, it is compromised of available bone height and width. Significant undercuts are seen. Okay, this is why it is challenging to put the implants in the posterior mandible. Usually people say it's easier to put in the posterior mandible, but there are some difficulties which we go through. One is a compromised available bone height and width. Second is significant undercuts we can see, difficult access, and vital structures like inferior alveolar nerve, mental nerve, etc. are seen. So as I have already told you that posterior mandible, it resorbs from buccal to lingual. Okay, so mostly the patient comes to you when most of the bone is gone, right? So you should know this thing, that it is buccal to lingual resorption which happens in the posterior mandible, which might lead to the improper placement of the implant. When limited alveolar ridge height exists, 4 options are usually available. First, you don't treat it, no treatment. Second is vertical ridge augmentation with delayed implant placement. Okay, and third option is vertical bone augmentation with simultaneous implant placement. Now, when I say vertical bone augmentation, it is the most difficult kind of bone augmentation, which is very challenging even for those who are those are very like very good implantologists. They might also, for them also it is difficult to do a vertical ridge augmentation, or you can go for a short implants. Mandibular flexure. Now, mandible flexes at the midline opening during the protrusive movement as a result of internal pterygoid muscle attachment on the ramus. The mandible also talks with the inferior border rotating out and up, and the crestal region rotating lingually. The movement is caused by masseter muscle during forceful biting or power function. So two muscles are important here, as actions are there. One is internal pterygoid muscles and one is the masseter muscles. Okay, so mandible between the mental foramen is relatively stable, but posterior to mandible foramen, it is not stable. There is some kind of flexures which are seen. Okay, so however, distal to foramen, there are considerable movements towards the midline on opening. So the body of mandible flexes distal to foramen. This is important key point, which why I'm repeating is, okay. And its clinical significance is when you are going for the full mouth rehabilitation. Okay. So whenever you are going full mouth, so for the maxilla, see if you, there is no flexure. Mandible, when you are going for the full mouth rehabilitation, this is the thing which causes problem. Okay, so when you are going for the full mouth implant prosthesis, what care should be taken? So the prosthesis, a full arch splinted prosthesis is fabricated. The patient exhibits complication. You cannot splint the whole, all the processes together in the mandible. If you do it in the maxilla, it's okay, not in the mandible, because the mandible flexes and the prosthesis should be ideally refabricated to allow the stress relief. Okay, so usually the anterior segments uh, between the mental foramen, they are splinted, and then the posterior segments are splinted. Then comes the inferior alveolar canal. So mandibular nerve give rise to the inferior alveolar nerve. Inferior border of the inferior head of lateral pterygoid muscle courses towards and enters the mandibular foramen on the medial aspect. It reaches premolar and divides into mental and incisive nerve. So it is important that your inferior alveolar nerve, it traverses further. Okay, it goes till the mental foramen and it divides into the mental and the incisive nerve. Now, we all know that it's a single canal going through, but it's not. Most of the time, you uh, you miss it to diagnose that there can be 2 or 3 rami, like 2 or 3 extensions. Okay, so it divides into 2 or 3 rami, and there are separate canals. As you can see in this image, there is this is called as a bifid, and this is a trifid inferior alveolar nerve. Okay, so with the conventional radiographic technique, you won't be able to see all these things. Okay, so suppose if this is the case, okay, and we have planned our implant according to this course, okay, and we are placing implant here, so you might damage the inferior alveolar nerve. So two-dimensional radiography is usually not recommended for the implant planning, but you have to take it for the initial assessment of the implant site. They do not give accurate position of inferior alveolar canal because of variable magnification factors. 3D radiography such as CT scan, CBCT, all these are required. So this is digital planning of the implant placement with the help of CBCT with respect to the nerve and all. Then we do so it's a different topic. So now anatomic consideration. So we divide the inferior alveolar canal into 2 planes. One is inferior superior plane, and one is buccolingual. So superior inferior plane, there is a concave path from posterior to anterior. So terminal segments will be mental nerve and the incisive nerve. Mental nerve through mental foramen and incisive through the incisive foramen. So Carter and Keene, they have divided it into type 1, type 2, type 3. Type 1 is in close proximation to the apices of teeth. Okay. Type 2, it is intermediate. So superior, inferiorly we are discussing. So this is close to the apices of teeth. Type 2 is intermediate, which is most common, and within it is in the middle of mandible. And type 3 is in the inferior border of mandible. So if we get this kind of ridge, it is a most favorable because we are getting a good amount of bone for the implant placement. But usually we find it in the type 1 or type 2. So again, it is high, intermediate, and low, same. So average distance of 3.5 to 5.4 millimeter from first and second molar root. So second is a buccolingual plane. Buccolingual plane, there are high degree of variations which are seen. It is said that you should keep 2 millimeter safety zone distance from the implant to this nerve, to this canal. So it can be buccal in the middle of the, or it can be lingual. So there should be 2 millimeter distance between the implant and the canal. Coming to the mental foramen. The mental foramen is an opening in the anterior-lateral aspect. This is important, okay? So it is an opening in the anterior-lateral aspect of the mandible, commonly in the interproximal space between the first and second premolar. This is what the books say, but most of the time it is not there. Okay, so it is between first and the second premolars. So many research and many things are happening to locate the mental foramen. With the advances like CBCT scan, we can now easily see where exactly the mental foramen is. So there are some variations which we can see. There can be 2 mental foramen, accessory foramen also. This is important. The anterior loop, mental foramen. This is seen in the most of the cases. Okay, so mental nerve, it proceeds anteriorly in the mandible. It sometimes runs inferior and anterior to mental foramen. It goes inferior and anterior to mental foramen and comes back to the foramen, which is, and then comes out. So this is an anterior loop. Okay, so this anterior and caudal component of the mental nerve will go back to the mental foramen, and this is termed as anterior loop. So now here we say that there should be 2 millimeter of the safe distance from the mental foramen and extra 1 millimeter or extra plus the length of the anterior loop. Now suppose the length of the anterior loop over here is 1 millimeter and the from the foramen it is 2 millimeters. So it will be 2 plus 1, that is 3 millimeter of safety zone should be maintained for the placement of implant. Then there can be an incisive nerve branch. Okay, this is one more variant. If you perforate this, there can be excessive bleeding, which will cause problems with accessibility. Then comes the lingual nerve. So lingual nerve is a branch of mandibular nerve again. It enters the oral cavity above the posterior edge of mylohyoid muscle, close to its origin at third molar region. Okay. Mandibular lingual tissue and anterior, it supplies mandibular lingual tissue and anterior 2/3 of the tongue. Now, lingual nerve is in close approximation with the retromolar pad. Okay, it lies just medial to the retromolar pad. Incision in this region should remain lateral to the retromolar pad. So whenever we are giving incision, it should be lateral to the retromolar pad so that we don't damage the lingual nerve. Lingual nerve is usually seen on the medial side of the retromolar pad. So, and second modification, what you can do is whenever you're reflecting the flap, okay, you should be in constant contact with the bone. Your periosteal elevator should be in the constant contact with the bone so that you're not damaging the lingual nerve. The improper reflection will lead to paresthesia or anesthesia. There will be loss of taste sensation as it supplies the anterior 2/3 of the tongue. There will be reduction of the salivary secretion as well. Now in the lingual nerve anatomy, there are some variations which can be seen. Okay, it can be in close proximity to the crest of ridge, that is a high variant position, and this is a low variant position. Now, muscular attachment of mandible. So one of the important is a mylohyoid muscle. Now we all know the attachments, that is it originates at the entire length of the mylohyoid line of the mandible bilaterally, entire length of the mylohyoid line bilaterally, and it inserts into the body of hyoid point and the medial raphe. Now, structures above the mylohyoid muscle are sublingual or it is intraoral. below the mylohyoid muscles are extraoral or subcutaneous. Now see, whenever there is resorption of ridge, this mylohyoid line from where the mylohyoid muscle originates will be in close approximation with the crest of ridge. Okay, so whenever we are giving incisions, reflections of the flap, you might damage this muscle. So surgical manipulation, it can lead to edematous sublingual space, swelling of submandibular space, ecchymosis sublingual or submandibular abscess or cellulitis, which is again a life-threatening situation. Now, extensive bilateral cellulitis of sublingual spaces may push tongue backwards and compress the pharynx, which may result in airway obstruction and necessitate to the tracheostomy or cricothyroidectomy to maintain the airway. Coming to the genioglossus muscles, again, here the importance is we all know the origin and insertion, that it originates from the superior genial tubercle, genioglossus, and geniohyoid. It originates from the inferior genial tubercle. So from superior genial tubercle, the anterior fibers are attached to the dorsal of tongue and posterior fibers are attached to the hyoid bone. So whenever there is resorption of ridge, it is close to the crest of ridge. So here, when taking an impressions, this area should be relieved. Okay, so this is our ideal mandible, but whenever there is resorption, it is closer to the crest of ridge. And when we are taking the impressions, this area should be relieved. Coming to the mentalis muscle. So mentalis muscle have origin from the mental protuberance and insertion inserts in the cheek and skin of chin and superior to the orbicularis oris muscle. So this is a mentalis muscle, okay? From the mental protuberance, it inserts superior to the skin of the chin and the orbicularis oris muscle. So this is of a clinical significance where whenever we are reflecting the flaps and there is muscle detachment, and after the healing, there is no reattachment of this muscle, it will lead to a wet skin appearance, which will appear like this, something like this clinically. So after reflection, usually a elastic bandage is applied externally to the chin to help in reattachment, or only reflect the distal portion and leave the proximal portion of the uh, muscle attached to the bone. If this happens, the patient might have to go for second surgery, which is a cosmetic orthognathic surgeries. So I would like to end my presentation by giving a take-home message that after this session, you now identify the anatomic structures which are relevant to the dental implantology and which are critically important. Understand the bone densities of the maxilla and mandible. Be aware of bone, arteries, veins, glands, and muscles of maxilla and mandible. Understand the anatomy of maxillary sinus, which are relevant clinically and important factors associated with that. So with this, I would like to end with a very beautiful quote that eyes only see what the mind knows. So once your basics of anatomy are clear, your surgery will be easy, planning will be easy, and there will be less chances of complications. Thank you for your patient listening.
Thank you so much, ma'am, for this very elaborative, comprehensive, and very informative session on the most important aspects in dental implant practice. That is, we need to know the clinical anatomy properly for successful clinical outcome. So that was very informative session. Thank you for your wonderful presentation.
Thank you.
Yes, so we now, dear participants, please note you have minutes time to put down your questions in the chat section or question answer section. So then we'll swiftly move on to the question answer session within a minute. After the successful completion of first virtual implant expo in the year 2020, Dentist Channel Online is now hosting World Implant Expo 2021, again with a bundle of very knowledgeable and distinguished speakers. So these are the speakers who will be delivering their scientific lectures all through the World Implant Expo 2021, which has commenced since today. So Dentist Channel Online is a leading dental media company. It aims to spread awareness and knowledge regarding various aspects of dentistry, both to dental professionals and also the general public. So Dentist Channel Online conducts regular webinars and courses on different areas of dentistry, which are being hosted on weekly and monthly basis. And also there is a special Prime membership for Dentist Channel Online, which brings several opportunities, accredited webinars and dental courses to the participants. So there is an excellent opportunity for every dental professional to be a Prime member of Dentist Channel Online. So this enables the participant to get accredited certificate after every course or every webinars. So there will be discounts and special offers on dental courses, online and offline, hands-on dental courses, and much more events and workshop in the coming days. So this is the certificate of participation, which would be given to the Prime members of Dentist Channel Online for participating in this World Implant Expo. Those who are not the members of Dentist Channel Online as a Prime member can still register as a Prime member by logging into our website, that is www.worldimplantexpo.com. So these are the upcoming webinars for today by Dr. Sundaram Rajan on CBCT in dental implantology, and a session on circumventing dental implants failures, that is tips and tricks by Dr. Shalan Verma, Dr. Mauro Marincolo on interproximal root spreading in cases of narrow spaces, and also another session by Dr. Saurabh Kamath on management of partially edentulous posterior sites. So these are the upcoming webinars for this day. So we expect you all to participate in these sessions also. We are really humbled and encouraged by the number of participants in this early morning session on the day of Diwali as well. So we expect the same encouragement and participation in all the upcoming webinars in World Implant Expo 2021. Thank you all the participants. So these are our sponsors. We once again take the opportunity to thank our sponsors, that is Mono Implant, Novamind, Qualia Implants, Simpladent, Unicorn Denmark, Bicon Dental Implants, JTK Implants Bangladesh, and Shastri Brothers from Bangalore. So we thank you for your support. And for all the latest dental updates, you can note down this number and contact Dentist Channel Online. And also please follow us on all the social media platforms, that is Facebook, Instagram, and YouTube. So dear participants, now we'll go on to the question answer session. And most of them have acknowledged that the session was very informative, and they have thanked our speaker for the wonderful presentation. One of the participants has asked about mandible flexure and need for splinting. Can you just highlight on this issue one?
Yeah. Okay. So mandible, as opposed to the maxilla, it flexes. Okay. So that is because of action of two muscles, that is the lateral pterygoid and the masseter muscle. So whenever you're opening and closing the jaw, the posterior mandible, it has a flexion movement. So whenever we are splinting, so when we are doing a full mouth prosthesis, usually in the full mouth rehabilitation, we splint the prosthesis. Why? To achieve more stability and distribution of the forces. So distribute, as opposed to the natural teeth, the implant is fused to bone. Okay, there are no periodontal ligaments. So our this thing is so that we should distributed the forces and increase the stability of implant in the long term. So we splint the implants. So whenever we splint the implants, the part which is between the mental foramen is stable as compared to the posterior mandible. So we do the splinting in sections, such as anterior, then the posterior, like that. So different segments. We cannot splint it once, because otherwise there will be some micro movements which will happen between the implant and the bone. and as I explained you, the bone implant interface. So there can be some amount of micro movements happening, and we don't want that. If there are some, can we splint the implant with the natural teeth? See, usually, ideally, we should not splint the implant with the natural teeth, because natural teeth have periodontal ligaments and fibers, but implants doesn't. So most of the time, your treatment planning should be such that there is no implant and natural teeth splinting. You can do two implants and splint, but no two natural teeth and implant splinting should be avoided.
Okay. I hope that answers the questions of our participants, and most of them have again expressed their thanks to you for the wonderful presentation, and some of them also have requested you to share the PDF of the presentation, so that I leave to the decision of the speaker.
Sure, you can
So if you
send.
wish, we can collect and then send to our participants. So once again, thank you, Dr. Vishruti, for your wonderful presentation and taking part in this World Implant Expo as a speaker. So on behalf of Dentistchannel Online, we extend hearty thanks to you for your presence in this World Implant Expo. And we also thank all the participants for taking your time and participating in this first session. So we request you to take part in all the other sessions as well. So see you all in the next scientific session for the day, and also all through the Virtual Implant Expo 2021. Thank you. Thank you one and all.
Thank you all for patience listening.
Yeah, thank you.